This is the biggest hit, that is teleradiology, because the images are floating all over the region. And if you want to follow what's happening in telemedicine, follow radiology, because they are used to look at images, they are used to sending and discuss it between colleagues. This hospital out in the Lofoten, there is only one doctor. At 4 o'clock at night, he go home, and the hospital of Bodø takes over the duty. When we have started to discuss why should a region like that be covered with 12 doctors on duty at the same time, when you can have one center and assistants to do the images, the organizational people think that we can save money. The doctors say no way, because half their salary is based on what they're doing after 4 o'clock at night. So there you have the struggle again. Yes, thank you. When you look into what's happening to radiology, that's a research from 99. You can double it with 10. When you use radiology instead of sending the patient, 34, and this was head injuries, 34% is avoided transportation, 42 patients had major changes in the treatment locally, and 13 patients had transportation initiated. They thought they could just put the patient to bed locally and not send them. So it has a major change on the quality given at the remote hospital. We are together with a lot of friends in an EU project where we have linked the networks in Denmark, Sweden, Norway, and the Baltic countries. And what's happening there is that the people in Denmark now are sending the images to Tallinn, where they are read, and the price there is half of the price of a doctor in Denmark. You could like it or not, but I'm completely convinced that this over the years are going to develop into a market where you sell and buy medical information in this way. You can say that it's not good enough, but it definitely is. And I do know that the EU on a central level is now making a list of all the doctors in all the European countries that are certified to be on that level and to participate in a group like that. This is another example. This is an arterial ulcer that is for elderly. They used to go from the nursing home to the hospital once a week. What we do now is to take this injury, we attach it, take in digital images. And by the way, my mobile phone in my pocket has a better quality than this that was developed 3 years ago. And they send that into the hospital. And at the hospital has reorganized. It's not a general practitioner referring a patient to a specialist. It's a nurse who is transferring the patient to a new group of specialized nurses. There are nurses from microbiology, there are nurses from dermatology, and there is nurses from surgery department that have a look on these patients. And it's functioning perfectly well. About distances. You see this northern part of Norway, this yellow circle. If you flip it, you cover Denmark and Sweden. If you take Spitsbergen up there, an island that are under the authority of Norway, and you flip that, you're all the way down to Spain. So we have pretty huge distances. 200,000 tourists are in Spitsbergen every year. So we have developed a system where you have a camera in the roof. That camera you steal from the university hospital. This is from a rehearsal. It's up on Spitsbergen. And you call the university hospital's emergency department. Images from the patient and all the vital signs from the patient are seen at the university hospital. And if this is working, it's not technology. Okay, but what you could see here that the eyes are in you could see a heart, a head injury in a way that it is in real life. So this is used by a lot of small hospitals and between general practitioners and the university hospital. That has been implemented like this based on video conferencing. In addition to this, we also have a lot of work done on portals for distant teaching. And this is in Norwegian only. But what we have done here is 2 years ago, we took the decision that we should move away from software companies that cost us €500,000 a year to open source portals developed in cooperation with the University of Toronto in Canada. So this is open source software, and we share it with wherever we like to do. And I'll give you a couple of examples of that. This is in Norwegian, but this is the courses that are available. It's about elderly, is physiotherapy, psychiatry, disease, eating disorders, and so on and so forth. There are 13,000 participating in these courses, put available to everybody who can read Norwegian on the net. This is also in Norwegian, but just to show how the technology has been integrated into teaching. This is the new faculty in Tromsø, that is for the dentist. The dentist also educate people to become specialists in orthopedic dentistry. These dentists have all the theoretical teaching from the University of Oslo and all the practical training done locally. So they're really taken this into university system and working on that. But as I was saying, the portal is open source. We have put the portal into English, and as the WHO Collaborating Center, we are traveling the globe. And this is another project where we link Jerusalem, Ramallah, Bethlehem, and Gaza City together in distant teaching for rehabilitation. And they connect to a hospital in Oslo, and in that way using the same portal. So it's not only in Norwegian. Another example is an organization called the Constellation for AIDS Competence. And just to show you the modern teaching room, classroom, it looks like this. This is the way we can use the portal. And once again, the portal is for free. Just use it. It's open source to train people in this area. When we have gone through this, we have found that in radiology, electronic patient record, distant teaching, dialysis, pre-hospital thrombolysis, psychiatry, dermatology, pediatric, ophthalmology, and ear, nose, and throat are services that are mature to go out on broad scale. But if you then ask some critical questions, have we been successful? And we could say yes, if we are talking about digitizing the past. We are mostly doing what we used to do and follow the same pattern that we used to do. We have not been able to do the integration between the electronic patient record system, and we have not at all organized improvement based upon implementation in the healthcare environment. What I'm thinking of is imagine what the banking has been doing, the way they have transferred our habits, the way they have created call centers and so on, and imagine the way the traveling business have taken us out of the offices and put us on the net, and we're doing all the work, and also for the banking. The healthcare system has not, we are not touching upon being a organization that are as efficient as those who are in the private business. And instead of me saying some rude and provocative things, I would like to quote a study from the National Center for Policy Analysis. Government insurance keeps medicine at Stone Age. It's not my words, but what they're saying is that the study noticed the biggest obstacles to information age medicine, commonly referred to as telemedicine, is government and traditional insurance, which only reimburses for a face-to-face consultation. Therefore, the most interesting developments in telemedicine are occurring outside traditional insurance, both by new medical services and by individual practitioners. And we have had struggled with that problems in Norway for 15 years. Me as an ENT doctor, if I see 10 patients on video conference, the hospital loses the income of 10 patients. But if I travel, or they travel to me, and we pay them for the traveling, and so on, the hospital is able to be reimbursed, and the director is extremely happy. So it's difficult to have high-level, high-rank directors saying to them, I have something very, very clever for you. You have to use this, and the more you use it, the more deficit you have in your budget. So